My name is Dr Bob Ryder from Birmingham in the United Kingdom, and I'm presenting today data from the UK's first National Health Service EndoBarrier service for refractory diabesity. These are my disclosures, and this is EndoBarrier, a 60 centimetre impermeable sleeve that's implanted during a simple endoscopy procedure into the first part of the small intestine, such that the food passes through it rather than the small intestine, and it mimics the bypass bit of the Roux-en-Y gastric bypass bariatric procedure. We've implanted 62 patients with EndoBarrier in our NHS service, and so far 46 have reached a year after the EndoBarrier was removed, and of these 32 attended for review. And this is their baseline data, and you can see that they were very obese with a BMI of nearly 42, hemoglobin A1C 9.5%, diabetes duration median 14 years, and 66% were taking insulin. So these are patients who are very obese, very poorly diabetes controlled, have had diabetes for a very long time and have tried all the standard treatments, and yet they remain obese and with poor glycaemic control. And this is what happened to them with the year of EndoBarrier treatment. They lost a mean of 17 kilograms, and the hemoglobin A1C improved to 7.4%, and there was a big improvement in systolic blood pressure and the requirement for insulin, with a third of the patients being able to discontinue insulin. When we saw them again a year later, 41% had sustained the full improvement they gained through the year of EndoBarrier, 37% partially sustained the improvement, and 22% reverted to baseline. And this is the data showing what I've just said, that the hemoglobin A1C remained fully improved in 41%, as did the weight, and there were 37% whose weight and hemoglobin A1C remained significantly improved compared to baseline, though there was some deterioration, and 22% reverted all the way back to baseline. When we talked to those 7 patients, most of them had experienced many problems in their lives and suffer from depression and bereavement. But that wasn't the whole story, because when we looked at these 7 patients, they had sustained much less weight loss and improvement in glycaemic control during the year with EndoBarrier. 5 of the patients had to have early removal of the EndoBarrier, 4 for GI bleed, 1 for liver abscess, but one of the GI bleeds could have been averted if the patient had followed the rules and hadn't reverted to normal food during the second week of EndoBarrier, when he was supposed to be eating only pureed food. And another patient ran out of his proton pump inhibitor and failed to replace it. He should have been taking a proton pump inhibitor to protect from GI bleed, but he didn't take it, and he had the bleed. But nevertheless, he'd lost 9.6 kilograms over 10 weeks, with a big improvement in his hemoglobin A1C and requirement for insulin. Another lady lost 8.2 kilograms during 2 months before her GI bleed. Another gentleman lost 6 kilograms with an improvement in hemoglobin A1C during 3 months before the GI bleed. And the liver abscess case lost 18.4 kilograms during the 7 months of EndoBarrier treatment before it had to be removed. So these patients all gained benefit and all made a full recovery. The hallmark of type 2 diabetes and obesity is hepatic insulin resistance and beta cell failure, and in association with the weight loss, there's also an improvement in alanine aminotransferase, which we've previously demonstrated associates with an improvement in liver fat, and we did MRI scanning before and after EndoBarrier in a number of patients in a research study, showing an improvement in liver and pancreatic fat. And we know from the work of Roy Taylor in Newcastle that this improvement in hepatic fat associates with a big improvement in hepatic insulin sensitivity, and the improvement in pancreatic fat is associated with improved insulin secretion. These are some of the patients I've been talking about. This lady was the first to go from obese BMI to normal BMI, and A year after removal of the EndoBarrier, she sustained the improvement. This lady had obstructive sleep apnea requiring CPAP, and after losing over 46 pounds, she no longer required CPAP, as well as a big improvement in her diabetes. And a year after removal, her improvement is sustained and she still doesn't need CPAP. This gentleman actually required ambulatory oxygen because he had interstitial lung disease as well as diabetes, and after losing 60 pounds he no longer required insulin and he no longer required ambulatory oxygen. And a year later he's a regular at the gym 5 days a week. And I mentioned that patients, a third of the patients no longer needed insulin after the EndoBarrier. This is one such, going from considerable obesity to a normal BMI, and prior to EndoBarrier she required 260 units a day, and a year later she requires no insulin. And these are all the insulin pens that she was consuming a year prior to the EndoBarrier, and you can imagine there's a lot of cost to this. And this is all the other paraphernalia that she no longer requires. She no longer requires glucose testing strips, pen needles, lancing devices and sharp spins, all coming with a cost. And a year and a half after removal of the EndoBarrier, she remains with the same improvements, and she's avoided 474 insulin pens because of the EndoBarrier weight loss. This is our summary and conclusion, which I leave you to read at leisure.